Video too? Okay, we're all set then. So good afternoon and welcome to this afternoon sessions of the Standing Committee on Health and Human Services. We're working on the budget. So the next chunk of time will be devoted to reviewing the proposed budget from the governor. And that'll be led by Luke Lazur. Before we start, I got dinged this morning because I forgot to turn off my cell phone in another committee. And we're not using the chat function except to keep the meeting going and not for any content. There won't be taking any testimony other than interpretation work by Luke Lazur and whoever joins us with expertise in that area. And so why don't we go around and introduce the committee, starting with Representative Zager.
Good afternoon, everyone. Thank you, Mr. Chair. Sam Zager, District 41 in Portland.
Representative Lemelin.
Good afternoon. Thank you, Senator. My name is Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Perry.
Good morning. I'm Representative Perry. I represent House District 140, which includes Indian Township, Baileyville, Barron, Carolus, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Griffin, yes.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescade.
Representative Madigan.
Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Senator Moore.
Good afternoon. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan and Hancock County as well.
And Representative Meyer.
Good afternoon and welcome to all who have joined us here today. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is parts of Kittery and South Berwick and all of Elliott.
And I'm Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. And we're joined by our crack staff. I'll let you introduce yourselves, starting with Aaron.
Hi, good afternoon. My name is Erin Dooling. I'm one of the legislative staff with the Office of Policy and Legal Analysis.
And Anna Broom.
Hi, I'm Anna Broom, and I'm the other legislative analyst with the Office of Policy and Legal Analysis.
And Carrie Withy.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
And we're also joined, as I said before, by Luke Lazur. So would you introduce yourself and carry on?
Yes, good morning. I am Luke Lazur. Afternoon, yes.
Don't listen to Representative Perry. We should have warned you about that.
I am Luke Lazur. I am from the Nonpartisan Office of Fiscal and Program Review, and I'm here today to help you walk through the last group of the budget. This is Group D, which includes Maine Care and the hospitals. So before I start, I was planning to not share my screen today with the budget, so I just want to make sure that everyone has their green document ready and at hand. And if that is an issue, I can share, but I thought it would be a little easier for everyone to see all the people in the meeting if I wasn't sharing my screen.
So unless we hear from you, everybody's all set, right? Okay, good. Thank you, Luke.
So we're going to start on page 17 of the green document at line 269. And this is lines 269 and 270. You'll see the first line is in the Maine Center for Disease Control and Prevention, account 0143. The second line is in the Office of Maine Care Services, account 0129, which is the administration account for Maine Care. This establishes one public health nurse consultant position, funded 25% general fund within the Maine Center for Disease Control and Prevention program, and 75% other special revenue funds in the Office of Maine Care Services program to oversee a mortality review committee for all home and community-based services waiver programs to ensure federal compliance and provides funding for related all other. You'll see the CDC portion is general fund and the main care portion is federal expenditures fund. I should point out, and I'm hoping that Molly's here because there has been a little back and forth. I believe there is some language that was not included in the budget that goes along with this particular initiative. So I was hoping to get her input and make sure that I'm right, that this is the initiative.
You should be joining us shortly.
Yeah, I'm sorry. Can you repeat that for me?
Yeah, sorry, Molly. So we're at lines 269 and 270, which are the public health nurse consultant for the mortality review. Wasn't this also needing some language that didn't make it in? So I just wanted to point that out to the committee that there is some language that also will need to be added here. And I believe it's coming in the change package as a plan.
I'm not sure, although I believe Representative Madigan has a similar bill to what she had last year that had the same language, compromise language that we agreed to. So we will, not exactly sure the vehicle quite yet, but we'll be sure to provide that.
And I guess what I'd note then for the committee is if you're interested in, when you vote for these lines, adding that language, we can find the language that's needed and make that part of sort of an amended vote for this line.
Luke, can I say something right here?
Please do.
This language, as you mentioned, we had last year, it had to be reviewed by the Judiciary Committee. And I'm assuming that because this is a new legislature, you'll need to get that reviewed by the Judiciary Committee again, because it has some confidentiality in it. So I just wanted to flag that for you. Sorry, Molly.
Thank you, Anna. I appreciate that. Not seeing any questions there. I'll move on to line 271. This is in the Office of Main Care Services admin account 0129. This reduces funding in the Office of Main Care Services program by recognizing ongoing savings achieved through general efficiencies and reestablishing priorities. And this is a reduction in each year of the biennium of $500,000 in the general fund. Okay. Not seeing any questions. I'll move on to line 272. This is also in the Office of Main Care Services admin account 0129. This adjusts funding to align with existing resources, and this is an increase to the federal expenditures funds allocation. Not seeing any questions. We'll move on to the next initiative, which is lines 290 through 305. I won't read all the accounts, but this adjusts funding as a result of the increase in the federal medical assistance percentage for federal fiscal years 2021 to 2023. So I will share my screen now just so I can show you a document which outlines all of these initiatives. I have also sent this to the committee, and it should be posted as well up on the committee page. So I just wanted you to see this document because it has all the same lines, 290 through 305. Can everyone see that? So it has 290 through 305, but at the bottom, you'll see that it gives you what the impact is by fund. So you can see that in 22, it is a decrease to the general fund appropriations of just over $2.5 million. It's an increase to the federal expenditures fund of just over $3.8 million. It's a reduction to the federal block grant funds of $1.1 million and a reduction to Fund for Healthy Maine of $107,000. And then you can see that in fiscal year 23, it's similar portions to each of those accounts. The general fund decrease is about $5 million. So again, all these are just due to the changing FMAP. This initiative does not have any relation to the 6.2% FMAP increase that we discussed in the supplemental budget. This is simply about the regular FMAP just changing for a fiscal year. Not seeing any questions there.
Well, there is one from Representative Perry.
Yeah, the question is, I guess, partly my curiosity. We're noting a decrease in the federal block grant. Is that a result of the increase in the FMAP, and why?
So yes, it is as a result of the increase in the FMAP. It does not change any of the program itself. And I will let Ben maybe speak to the why, because it has been a while since I've been there, so I don't want to speak incorrectly about why that actually occurs, but I do know that that's what happens anytime we do these FMAP changes.
Yeah, that's generally right. It just needs to tie to zero, and there's a corresponding decrease to the block grant side, a corresponding increase to 013 to the federal expenditures fund. I can get more information. I don't have it at my fingertips exactly the differentiation between the block grant and the federal expenditures.
But the net is zero.
The net is zero. This is all because of the FMAP rate. You can see it in the description. It's changing slightly. It's increasing. So we have a reduction of the corresponding funds, mostly general fund.
And this is a FMAP change that doesn't have anything to do with the pandemic.
That's correct. This happens every single year. Just to go down one level, the FMAP is tied to the federal fiscal year, which is October 1 to September 30. Obviously, our fiscal year is July 1 to June 30th. So we have, you see in the description there, it refers to a blended rate because we have different quarters in since the state and the federal fiscal years don't line up. We have to blend the FMAPs together. Every state does this. And this is something that happens every year. There's marginal incremental changes, either up or down for the FMAP, which would then have a corresponding impact on the general fund side.
One more question, sorry. The federal block grant, what does that cover?
I know CHIP, Children's Health Insurance Program, is all block granted. I would have to follow up exactly on the distinctions between the block grant and the federal expenditures for you.
I'd appreciate that.
Okay.
That I'll stop sharing my screen and just go back to looking at your green documents. We're now up to line 306. So the next initiative is 306 and 307. This particular initiative relates to hospitals. The next few initiatives are the hospital initiatives. We do always just break those out separately, both on this document and on the schedule that I gave. So I just wanted you to know where these were coming from. So line 306 and 307 are both in the medical care payments to providers account, which, as I've said a couple times, is called the MAP account. This is account 0147. This adjusts funding in order to claim enhanced expansion federal medical assistance percentage rates for biannual hospital supplemental payments. So I'll just note that what this is and what makes it a distinction from what we just discussed in an FMAP change is that it looks like they were changing how much of the supplemental payments that go to hospitals were for individuals who are on Medicaid expansion as opposed to regular Medicaid. So it increased the federal portion of these payments that go out twice a year. And so what this change is doing is decreasing the general fund and increasing the federal expenditures funds for that new percentage that they've allocated for the supplemental payments.
Does this have any impact to the hospitals?
It does not. You can see row 306 is the exact amount of the row 307. We are shifting costs or payments from the general fund side to the federal expenditure side. And Luke did a great job explaining FMAP. I don't want to overcomplicate this, but it might be helpful to think about because several initiatives are going to come up during today. We just discussed on line 290, just the regular FMAP, which is that happens annually and it goes up or down, and we make the corresponding adjustments to the general fund side. We've previously discussed the 6.2% increase, which is tied to the public health emergency, and that is a special exception that happens very infrequently and tied to the requirement to keep members on the rolls during the public health emergency, and also any impact from economic downward economic pressures that would all further increase enrollment during economic downturns. There's two other types of FMAP changes. This is one of them to incentivize states to expand their Medicaid programs under the ACA. The federal government matching rate for expansion members is typically 90-10, 90% federal, 10% state. We are making several changes in this budget to adjust those percentages because we can, like this initiative does, we can appropriately shift costs to the federal side instead of the general fund side because of that enhanced FMAP rate tied to expansion. And that's what this does. The final one, and I think I could mention it later on when we get to it, there's other claims that come in that are eligible to be matched at a higher rate that our systems, for one reason or another, haven't done that. And we're making those changes because, again, there's no impact to providers. We're just shifting the matching rate between state and federal dollars. And there's the same amount of money will get pushed out, but it's just at a different split between the federal and the state.
I note that Representative Stover has joined us. Would you like to introduce yourself off of mute and say hi?
Good afternoon. My name is Holly Stover. I represent House District 89. Thank you.
Thank you. Luke, I note that these numbers we're working on now are not on the initiatives list that I got, so maybe there's an updated one. But
no, they're there. That's where I was saying these are under the hospitals. So if you look at the list, it said main care, and then there was another block for hospitals.
Thank you.
And
very
these
much.
are the ones that are in that hospitals group. So I know they're kind of in the middle of things, but we've always broken them out. So
that's fine. Thank you.
So we're up to lines 308 and 309. These are both in the MAP account 0147. These adjust funding and the medical care payments to providers program between the general fund and other special revenue funds related to rebasing the hospital tax year from fiscal year 2015-16 to 2017-18. So about this, I'll note that first there is language part 00, which we'll get to when we get to the language parts. This is an annual change that's done in the budget. For the other taxes, the nursing facility tax and the service provider tax, the taxable amount changes every year based on other information. With the hospitals, it's set in statute to change. It's only changed when statutes change. So each budget, what's done is it's basically changing the hospital taxable year to the most recent cost reported year, which in this case is 2017-18. So that's why this change is being done. You'll see that what's happening is the general fund is being reduced. The general fund appropriation is being reduced by 11.8 million, and the other special revenue is being increased by 11.8 million. What that means is, based on this new taxable year that's being applied, there will be an additional 11.8 million in revenue that will come in to the department from the hospitals, thus reducing by 11.8 million the amount of funding that needs to be appropriated. I'll also note with this particular initiative ties to some other initiatives we're going to come to in a minute. So this rebasing is seen in this document in a few places, and I just wanted to make sure you sort of knew there's more to come related to this.
Yes, Representative Perry.
Yeah, sorry again. My understanding is that the hospital tax where the hospital is to be revenue neutral. Is that something that's coming up in the rest of this, or is this a change?
That piece is coming up. I'll say this. I think what you're saying is that it's meant to be revenue neutral. There's no language that really says it has to be revenue neutral. The fact is that when it was originally created, it was done in a way to make it revenue neutral. And so this change has happened every year. And in some of our previous budgets, there has been no additional funding going to the hospitals related to this. In this budget, there is. It's coming up in a few lines. And we'll talk about that a bit more when we get there.
Senator Moore.
And that may answer my question, Senator Claxton. Thank you. I just want to, I guess my question was asking, what is the hospital paying currently, and is this an increase? And that's what would be a concern.
Yeah, so what this is based on this new tax, the hospitals will be paying the state an additional 11.8 million.
Wow.
When we get to the other initiative, we'll talk a bit more about that difference that you're referring to. What, are the hospitals being made whole? So we'll talk about that when we get to those lines.
Okay, thank you.
Okay.
All right. Not seeing any more questions. I'll move on to lines 310 and 311. These again are both in the MAP account 0147. This adjusts funding in order to claim enhanced expansion federal medical assistance percentage rates for weekly hospital prospective interim payments for treatment related to the Medicaid expansion populations. So again, like the initiative we went over, I think it was lines 306, 307. This is related specifically to that Medicaid expansion population, which gets that 90% federal match. These prospective interim payments are payments that are made every year to certain hospitals. And this is just changing the way the payment's done to get more federal match on those payments for the Medicaid expansion population. In this case, the general fund appropriation is being reduced by just under 13.5 million, and the federal expenditures fund allocation is being increased by the same amount. So again, it's moving the funding from general fund to federal, but it has no impact on the amount of dollars going out the door to the hospitals. All right, not seeing any questions. We're up to lines 312 and 313. These lines are the ones that discuss the payment that Representative Perry and Senator Moore were questioning. So these are also in the MAP account 0147. This provides funding to increase the supplemental payments to hospitals. So earlier we talked about the supplemental payment being changed for Medicaid expansion. This is an increase to that supplemental payment and how much will actually go out the door. And I'll just note that what you have is an increase of $3.1 million general fund and an increase of $8.1 million federal expenditures fund. When you sum those dollars up, you end up with just over $11.2 million. Compare that to lines 308, 309, where the rebasing was happening, and the hospitals are going to be paying back an additional 11.8 million. The difference between those numbers, in other words, I'd say the difference between what the hospitals will be paying and what they'll be getting back, they're getting back $530,491 less than what they're paying in that increased tax. So that's sort of the difference between those lines.
Could you give me that number again, Luke?
Sure. It's $530,491.
Thank you.
Seeing any questions, I'll move on to lines 314 through 318. This is in the state-funded foster care adoption assistance account 0139, the MAP account 0147, the Office of Substance Abuse and Mental Health Services account Z202. There's more in the MAP account. This is for federal expenditures funds in 0147. And there is another special revenue allocation increase in the mental health services community Z201. This provides funding for a new intensive outpatient program for high acuity main care members to address the gap in the state's behavioral health service system. In total, this is a $6.8 million increase in both years, and about 1 million, just over 1 million of that is general fund dollars. The remainder is federal expenditures and other special revenue funding. Seeing no questions, I'll move on to lines 319 through 322. This is the first of a few of these consolidation-related initiatives. We went over one of them on Thursday that had to do with developmental disabilities and intellectual disabilities programs and the waivers that are related to them. This one provides funding to the medical care payments to provider program and decreases funding in the low-cost drugs for Maine elderlies program, the mental health services community Medicaid program, and the Office of Substance Abuse and Mental Health Services Medicaid SEED program to consolidate the 4 Medicaid assistance programs into one program as part of the consolidation of main care related programs from 13 to 4. So I think, again, I'm going to share my screen so we can look at the program consolidation file. So here we are, lines 319, 20, 21, and 22. So I'll note that the account that is receiving the funding is the medical care payments to providers, account 0147. So that's where all the funding is going. This is all general fund dollars. So these disparate programs all fund different services using some portion of Medicaid dollars. The low-cost drugs for the elderly program has always been in its own appropriation, 0202. I did note on this document that I am able to still track the costs in that program because there is a separate field in the accounting system that I can go to that actually has different codes that were only used for these accounts. So I can still track the funding that is in that account. It's a little more difficult because it doesn't have its own appropriation, but it is still able to be done. The other 2 accounts that are moving funding to the MAP account, Z201 and Z202, that funding was never looked at the appropriation level for me. It was never something that I did. I only looked at it based on a different field in the accounting system anyway. So this really has no impact on the work that I do and my ability to answer questions for the legislature. I will also note this is the one program consolidation that you'll see that the net impact of all the movement is actually a $3 million reduction each year of the biennium in the appropriation to general fund. These are all for our general fund accounts. And in the end, if you sum them all up, you end up with negative $3 million. So there is some savings related to this particular initiative.
Yes, Representative Perry.
Thank you. Sorry to ask so many questions, but I think we've already asked this, but I just want to double check, is with all the program consolidations, and these are important programs, exactly where are the savings being found, and are the programs still unaffected in terms of their ability to provide their services?
Correct. They're still unaffected. There's no impact to the bottom line of any claims that are paid out of the main care account. The reason why we're offering up $3 million related to this initiative is due, it's just sort of the financial representation of the efficiencies that we think and will realize because of the consolidation. By combining the 13 general fund accounts to 4, we'll need less reserve in each of them because we'll be paying claims out of fewer accounts. And because of that, we project we could save without any impact to providers $3 million on an annual basis. So we can remove that. We typically, you may have heard me say before that we typically aim to carry at the end of the year 1 to 2 cycles payments worth of money. That would be reduced by $3 million if we consolidate the accounts because of the, like I said, the efficiencies that we can gain just having fewer accounts to manage and less reserve in each of those accounts that we would need to make sure we maintain.
Does that answer your question, Representative Perry?
Sort of.
So it's an accounting change, not a program change, in essence.
Except with the savings and less reserve, are we also saving in administration of those accounts?
The saving, there's a, that's just done with state lines. There's a small team that does that. They have, there's plenty of analysis work to be done other than managing these cycle payments.
So the savings is allowing us for a smaller reserve net.
Yes.
Okay. Thank you. And don't apologize for asking questions, Representative Perry. That's why we're here.
All right, if there are no other questions, then we'll move on to lines 323 and 324. And I'm going to keep sharing my screen because these lines, again, are on the same document. These are in the nursing facility account, which is going to be receiving the funding, account 0148, and the PNMI room and board account, account Z009. PNMI stands for private non-medical institution. That's just a term that we use within the main care system for certain facilities. So it is increasing funding in the nursing facility program and decreases funding in the private non-medical institutions room and board account to consolidate the 2 residential programs into one program as part of the consolidation of main care related programs from 13 to 4. So I'll note back on the consolidation document that these are both general fund accounts. You can see that the dollar amounts offset, so there's 0 impact to general fund appropriations from this change. Again, the nursing facility account is receiving the funding, so its appropriation is going up. The room and board accounts appropriation is going down. There really is no impact on the ability for me to track this funding. They're already, again, outlined in a separate code within the accounting system, so I'm able to track all of that PNMI room and board. And just for reference, the reason that there is a separate general fund account currently and why this funding is separate for room and board is that in these private non-medical institutions, there is no ability to pay for the room and board using federal funds. And so it's all general fund. So it's always been broken out separately just to keep track of it.
So without asking the specifics, because I'm sure you've thought about it and I probably can't keep up with you, but have you entertained how this would look in subsequent years? Because we'll no longer have a baseline for comparison for several of these categories. So just a heads up that some of us legislators would need help making that transition in a couple of years from now.
And I know that is the really only concern from my perspective as well, because most of this funding can still be tracked in one way or another. I think it's comforting to see the separate appropriations. It makes it a little easier to see the history of things. And I know that Ben has mentioned, and he and I will probably talk if this were to go through, about trying to keep tabs on a lot of this information outside of having to have them in their own separate approps, but still reporting the information to us in that weekly file that we send across monthly to the committees. And I think that might be a good way to sort of keep tabs on some of this, to have that history, because you're right, this does make it a little more difficult. I still have the history. I can still go find the history in the accounting system, but it's not right there on the baseline document for everyone to see right away. So that is a bit of a change.
Thank you for being aware of that. I think it's going to be very helpful in the future that certain of these specific programs are trackable to some extent, especially if it doesn't interfere with accounting efficiencies. Okay.
All right, so I'm going to move on. So I'm going to stop sharing for a moment. We're moving on to lines 325 and 326. These are both in the MAP account 0147. This provides funding to modify the main care estate recovery rules to the mandatory federal requirement. I will note that the way that the main care estate recovery works in this section, it notes that the recovery can be done either for all services or the federal minimum, which is a certain set of services. And I believe the idea here is to change to that more limited estate recovery. That leads to needing an additional appropriation of general fund dollars because there will be less recoveries done, and thus will have to pay more on services. The general fund impact is an increase of just over $400,000 each year of the biennium.
I notice we've been joined by Representative Craven. You want to unmute yourself and say hi?
Thank you, Mr. Chair. Hi, my computer broke, so I am attending on my teensy-weensy phone. So I'm Margaret Craven, and I represent District 59, which is part of Lewiston. Thank you.
Welcome. Thank you, Luke.
Not a problem. So if there are no questions about that particular initiative.
So Luke, sorry to interrupt you. On that initiative, on the state recovery, when this initiative was considered in prior years, there was language needed in order to effectuate it, and Representative Perry had a separate bill that would have accomplished the same thing. So that language exists, but it can be added as an amendment for voting purposes, just like the mortality review board that was mentioned earlier.
Thank you, Aaron. Yeah, I had that note on my document, but I overlooked it while I was walking through this. If there are no other questions, I'll move on to lines 327 through 330. This is another consolidation. This one is in the nursing facility account 0148, the residential treatment facilities assessment account Z197, the Medicaid services developmental services account Z210, and the developmental disabled, intellectually disabled services waiver supports account Z212. This increases funding in the nursing facilities program and decreases funding in the residential treatment facilities assessment program, the Medicaid services developmental services program, and the developmental services waiver supports program to consolidate the four programs into one as part of the consolidation of main care related programs and accounts. So I'll again quickly share my screen so we can look at that. And I'll note the difference with this consolidation and the next consolidation. This is all other special revenue. There is no movement of any general fund dollars. This is simply consolidating the revenue that comes in from, in this case, it's nursing facility tax, and then there's also a residential treatment facilities tax that's part of the service provider taxes. So this is taking the estimated account information that's in the other special revenue at the moment and moving all that funding, all those allocations to the nursing facility account. This has zero practical impact. I don't believe this even really has any of the issues that we noted above, because how much this tax is, I can identify other places and already do for the Revenue Forecasting Committee. So there's really not much of a concern here. These accounts are just going to all move into the nursing facility account, and that'll be the one account where this revenue now goes. This, again, just makes it a lot easier for the department as far as doing journal entries that are related to these taxes. And I'm sure that's why this is being considered. Seeing no questions, I'll move on to the next one, which is lines 331 through 334. This is similar to the one we just looked at. It's also all other special revenues and all related to taxes. So this is in the medical care payments to provider account 0147, the mental health services community Medicaid program, the Office of Substance Abuse Mental Health Services Medicaid Seed program, and the Medicaid Services Developmental Services program. So this increases funding in the MAP account and decreases funding in the other three accounts I just mentioned to consolidate the four programs into one as part of the consolidation of main care related programs. So I will again show you on this document that this is all other special revenue accounts. It sums to zero. All the funding from the three other accounts moves to the MAP account. And again, it has very little impact structurally. All this funding is still accounted for in the Revenue Forecasting Committee report, and so it's still tracked in another place. Not seeing any questions there either. I will move on. This next one also is a consolidation, so I'll keep my screen up. So this is accounts 335 and 336. This increases funding in the Medicaid Services Developmental Services Program, which is account Z201, and decreases funding in the Mental Health Services Community Medicaid Program, which is account Z210, to consolidate the two programs into one as part of the consolidation of main care related programs and accounts. Similar to the ones we've just discussed, it's other special revenue. It again has to do with the service provider tax, and it's just moving the funding from one account to another with a net zero impact to the other special revenue funds allocations. And the last consolidation we have is lines 337 and 338. It again is combining two programs, but I'll note here that if you look at the account, they're both MAP accounts, account 0147. So this really has no impact when it comes to budgetarily, because in the budget, the furthest down we look at an account is at that account 0147 level. This is below that at a unit level, which you don't see in the big budget document. I do see it in my system and it is broken out, but it's all in this account, the MAP account already. It just moves the funding from one unit to another, just to make things a little easier within the account. So it's moving 676,000 from one of the accounts to another account. That has zero impact on the appropriations or allocations of these programs.
So obviously somebody's looked at this accounting process and established that it won't impact our ability to keep the feds happy when they audit, I assume. And do we share tips and tricks with other state funding entities, and how, I mean, are other states consolidating from 13 to 4 and 2 to 1 and 4 to 1 is the general question.
I don't know the answer to that. I think the current construction of the accounting backend for main care, I think, is a vestige of that is accreted over time, decades in likelihood. Some of the reports that Luke referred to before, I still think have accounts that are defunct back when DHHS was merged and created from two different departments. So this is really, I would just summarize it as a cleanup effort to try to consolidate similar accounts, both on the general fund side and the tax side, which is the most recent initiatives that Luke just went through.
Okay.
And I'll note to the the keeping the feds happy portion of that question, the way that we report to the feds is completely, in a sense, unrelated to the way we structured our accounting system. I know because I was with the department and created a couple of these accounts at one point or another. And as we just needed to make sure in the accounting system, there's a way for us to track which accounts need to get which FMAP, because that's how the feds care about things. When you report to them, you're reporting at a really, really high level. You're just making sure that you're saying how many expenditures happened at the regular FMAP. There is a little more detail than that, but it's not nearly as detailed as what's in our accounting system. So the accounting system can still track everything the way it needs to report correctly to the Fed. So that's the key. And I would say trying to compare us to other states would be an impossible task, just because every state does their their Medicaid system very, very differently. And so there isn't a real correlation there. This is more about how do we account for activity in our accounting system and how do we account for it in the budget. And this is just trying, I think, to make things a little easier on the accounting side.
Thank you.
All right, so I'll stop sharing again. We're up to lines 339 and 340. These are both in the MAP account 0147. This reduces outpatient reimbursements to 100% of costs for facilities meeting the federal regulatory definition of institutes for mental disease. I'll just note, because the justification outlines this, that currently institutes for mental disease outpatient services are cost settled at 117% of cost. This would move that to 100% of cost.
Speak to the history of how we got to 117.
I'm not, I might have that in my notes. I don't have that in my fingertips right now. I know it's been in place since 2006. But we are proposing this, I think, as part of the overall suite of savings that the department looked at, and given that we are reimbursing at 117% of cost, it's best practice to cover costs for reimbursement, and by definition, these providers are getting paid $1.17 for every dollar that they spend. There should be no impact for clients served or services delivered, since we're not reducing reimbursement below cost right now through this. I would just also note that the comprehensive rate system evaluation, which I still believe you're going to get a briefing on from our main care director, recommends moving away from cost settlement, since there's no incentive for cost containment based in a cost settled environment, and it's not tied to quality of care either. So we'd like to move to a more performance-based system that incentivizes both of those items.
Yeah, Dr. Probert will be in front of the committee in the next week or two talking about the value-based purchasing. I also have been associated, as a trustee, I know that there are some product lines that are loss leaders, and there are some that help fill the holes. And it'd be interesting to know what the impact of this was on some of the other places where they're not being reimbursed at cost. And I don't know how to ask that question, but I suspect that there are other line items in hospital budgets where they lose money. And this was an attempt to keep them whole or to keep a service in it going in a community. So we'll probably hear from the hospitals at some point in the conversation. Thank you.
No other questions. I'll move on to lines 341, 342. These are, again, are both in the MAP account 0147. This eliminates the exception for psychiatric units rates per discharge. As a little more detail, there are two facilities, Northern Maine Medical Center and St. Mary's Regional Medical Center, which have their own distinct discharge rates for these services. And this would eliminate those separate rates per discharge and move them all to one discharge rate, which the standard rate currently is $6,438.72 per discharge. This has a savings to the general fund of just over $700,000 each year of the biennium.
Yes, Representative Zager.
Thank you, Senator. I'm just wondering what the history is. Is there a reason why the rate was added, and if so, what has changed?
I'm not totally up to speed on all the changes. I do know that it's in state law. It was passed previously to have exception rates for those two facilities. You've heard me say before, I think the saving, we cast a wide net and pared back for the savings that we needed to offer up, both for the fiscal environment that we're in and also to fund other priorities. That one of our criteria that we used was to pay out equal, equitable rates for similar services, and this seemed like a good candidate for that, since these services are the same, yet there are differential rates being paid to different providers. So standardizing that ensures better parity and equity across the system, and standardizes that payment for all providers.
Thank you.
Next is lines 343, 344. These are both in the MAP account 0147. It reduces funding in the medical care payments to providers program due to a one-time anticipated reduction pursuant to the department's rule chapter 101 main care benefits manual chapter 2 section 113 non-emergency transportation services broker payments for fiscal year 21-22. So as you can see, this is in the general fund and federal expenditures funds, and it's just in the first year of the biennium, state fiscal year 22, and this has a reduction of $732,809 in state fiscal year 22's appropriation to the general fund. Move on to lines 345 and 346. This is in the MAP account 0147. It adjusts funding for changes instituted in the main integrated health management solution system to require providers to follow certain billing procedures to correctly identify family planning claims. This was also, I believe, in the supplemental budget. This extends that change and puts it into the baseline now. And this has an impact of just over $1.2 million reduction to the general fund, with a corresponding increase to the federal expenditures funds. This relates to essentially the FMAP that you receive for certain claims. For these family planning claims that need to be identified, there's a 90% federal match. So this, by identifying more claims that meet this criteria, they're able to get an additional federal match on those claims. And that's where the savings to the general fund come from. Next is lines 347, 348, 349. These are all in the MAP account 0147. This reduces funding for savings achieved by establishing a reimbursement methodology that reimburses providers under the federal 340B program at the approximate cost of physician-administered drugs under that program. There was a similar initiative in the supplemental budget for this. This has a general fund reduction of just over $2 million in each year of the biennium. And then there are corresponding federal expenditures fund and federal block grant reductions as well. Move on to lines 350, 351. So both in the MAP account 0147. This adjusts funding as a result of maximizing the federal medical assistance percentage by incorporating primary care case management, primary care health homes, and primary care provider incentive payments into population-based payments that are directly tied to performance on quality, utilization, and cost measures. This has a general fund savings each year of the biennium, just over $50,000. Next, lines 352 through 354. These are all in the MAP account 0147. This reduces funding to align the rate structures and fee schedule for purchased durable medical equipment with those used by the Federal Department of Health and Human Services Center for Medicare and Medicaid Services. Again, I believe this relates to an initiative that was in the supplemental budget. This puts it into the baseline. This has a general fund impact of a reduction of just over $200,000 each year of the biennium. Senator Claxton, I think you're on mute, so I think you were looking
Sorry.
to.
Yes, thank you.
ask a
Thank you.
question.
Thank you. Representative Perry, as long as you don't apologize. You're now on mute still, Representative Perry. Do you have a question? It's contagious.
It is contagious. I did have a question on the durable medical equipment and the decrease. Is it changing what is covered, or is it changing to fit with what the federal government is doing? Sir, you're on mute.
It is contagious.
I caught it too. It is changing because we are currently owe CMS a financial penalty based on the fact that we are over the upper payment limit on durable medical equipment. So there's several ways that we are going to propose on reducing what we pay out to make it more in line, to make it permissible with CMS. We talked a little bit about this a while back on there's differentials between urban and rural splits with how where a certain provider is. There's also some determinations that we can make around when someone should rent a piece of durable medical equipment versus purchase that will try to minimize the impact to this community. But these, if we're currently exceeding that limit, and so this is certainly a compliance issue in our eyes to get under that limit. So we're not racking up additional costs on top of the excess payments that we're making right now.
Just one more question in terms of the upper payment limit. We had a long discussion last session about how that was assessed and calculated. And has there been any work or any movement in changing how the calculation is going?
Good memory. So there's different services are tied to different UPLs, upper payment limits. So what you just referenced was in line with nursing facilities, and we did do some work on that front. This is this upper payment limit is specific to just durable medical equipment.
Representative Craven, did you have a question?
Thank you, Mr. Chair. I did, but I found the answer myself. Thank you.
Okay. And what's the total spend on DME in this account? And what does the 200,000 represent as a percentage roughly?
That's a good question. I'll have to follow up with you. I don't have that number off the top of my head.
Okay. Thank you. All right.
So we'll move to lines 355 through 357. Again, all in the MAP account, 0147, provides funding for an increase in the rates for federally qualified health centers, FQHCs, as required by the Federal Department of Health and Human Services Center for Medicare and Medicaid Services. So this is just an annual increase that is required by CMS for FQHCs. It has an increase in general fund expenditures of just under $300,000 each year of the biennium.
Okay.
Next, we'll move on to lines 358, 359, and 360, all in the MAP account, 0147. This provides funding for an increase in rates for rural health centers, the RHCs, as required by the Federal Department of Health and Human Services Center for Medicare and Medicaid Services. It's very similar to the FQHC rate increase. This is just for the rural health centers. Next is lines 361, 362, and 363. These are in the MAP account 0147 and the PNMI room and board account Z009. This provides for cost of living adjustments for adult family care homes. And this has a general fund increase of around $100,000 each year of the biennium.
What do we use for cost of living increase? Is that the formal term? It's not medical cost of medical increase. It's not.
There are different
CPI?
COLAs that are. Sorry, there are different COLAs that are outlined in statute that must be increased, and they do have different reference points. The one that's often been used is the medical care services CPI, which if you go to the Department of, it's Department of Labor website, they have all these CPIs, and they're listed out. There are many different service sectors that are outlined with their own CPIs. And I'm not positive, but I believe the adult family care homes and the nursing facilities currently use medical care services CPI as their increase. But I believe we're going to get some language later that will actually change what the nursing facilities use for their CPI, if I remember right. So
okay.
I'll see if Ben has anything to add to that, but that's the basics.
We do have language to align to our regs and state plan that we have in with CMS. There's this particular CPI, a particular COLA that is made for nursing facilities. So it makes sense to align it to that.
And I should know, I kept saying CPIs, but I'll just note that's consumer price index.
It's index, yeah.
Yeah.
Thank you.
We'll move on to lines 364 through 366. These are in the MAP account 0147 and the low cost drugs to Maine's elderly program 0202. This eliminates the pharmacy incentive payment to pharmacies serving Maine Care members residing in rural areas. This has a savings to the general fund of around $700,000 each year of the biennium between the two accounts that are general fund. All right, next is lines 367.
Sorry, Mr. Chair.
Oh, I'm sorry, Representative Zager.
Thank you. I'm wondering, how does that affect access to medicines to rural Mainers? Is that accounted for through some other efficiencies or mail order pharmacies or other mechanisms in the system?
Well, some of this information is included in the justification, but the supplemental dispensing fee for rural providers was put in place when the dispensing fee was $3.30. It has since been increased to $11.89. So that certainly subsumes any cost concerns on that front, and it has been since 2018. So removing that would presumably have little impact, considering that we nearly tripled the rate for the dispensing fee a couple of years ago.
I appreciate that.
It's literally the next initiative. We are proposing to modestly reduce that dispensing fee from $11.89 to $10.59.
Seeing no other questions, and with that lead in, we'll move to lines 367, 368, 369, which are in the MAP account 0147 and the low cost drugs to Maine elderly account 0202. And as Deputy Commissioner Mann said, it reduces the Maine Care prescription drug dispensing fee, which is currently at $11.89 to $10.59. And this has a general fund impact of just over $1.7 million each year of the biennium. That's a reduction to the appropriation of just over 1.7 million each year.
I just note to correct the record, the description is slightly off. $11.89 is what we currently pay in Maine for dispensing fees, and the $10.59 is New England average, not the national average.
Thank you. That's helpful because that might have got me confused later when I came back to this. So I'll try and make note of that. Next is lines 370 and 371, both in the MAP account 0147. This adjusts funding between the general fund and other special revenue funds within the main care pharmacy program to reflect the drug rebates received. So this relates, as it says, directly to drug rebates. Those are rebates that we as a state have gone to different pharmacy providers, and we get these certain amounts back for each of the drugs that we pay for. There are set fees, set rebates. They're set largely by the state. Some are directly from the federal government. The federal government receives their portion, the state gets their portion. But what this is doing is just adjusting how much, based on how much revenue we expect to get. So the current allocation was low for the drug rebates, and this brings the allocation up by $9.79 million in each year of the biennium, which then has a corresponding reduction to the general fund appropriation of $9.79 million. So this is similar to some of the other initiatives, and that is just taking, there is an expectation that the revenue is going to be quite a bit greater than what the current allocation is, and this brings the allocation in line. But because specifically what this revenue does, it reduces the general fund appropriation by the same amount. Seeing no questions, I'll move on to lines 372 and 373, both in the MAP account 0147. This reduces funding in the medical care payments to providers program by developing a preferred drug list and prior authorization process for physician administered drugs when there are biosimilar equivalents eligible for rebates. This has a general fund reduction in each year of the biennium of around $600,000 and a federal expenditures fund allocation reduction of around $1.4 million each year of the biennium.
Who determines the biosimilar equivalence? How's that done?
We have a pharmacy team that would work in tandem with the manufacturer, the folks that handle the pharmacy program to be able to do that. I think they would. My understanding is that there would be no controversy for the determination of any biosimilar drugs, though.
Excuse me if I chuckle, because somebody's ox is going to get gored here. There's always the opportunity for controversy when you talk about drug equivalency, whether it's aspirin or biosimilars. Sorry, I digress.
Actually, let me just add to that. I put a bill in last session that went by the federal designation of what biosimilar is and will not be considered a biosimilar until it meets FDA definition.
So we'll move on now to the last initiative on the green document for the main care portion. This is lines 374 through 384. This adjusts funding in the Medicaid dedicated tax accounts and the corresponding general fund accounts to bring baseline resources in line with the December 2020 Revenue Forecasting Committee recommendations. So I am going to share screen again so I can show you a document that tries to, as much as I can, outline all of this. So this document here has all those lines, 374 through 384. And you can see it's listing all the accounts. Some of them are general fund, some are other special revenue. That's because the funding, when the taxes are changed in these particular accounts, the general fund has to change to go along with it, because all the funding that comes into these accounts essentially offsets some general fund spending. And so if the estimated tax that we're expecting to come in goes down, we need to increase general fund appropriations to account for that loss. So I'll just show you at the very bottom of this document. It outlines what the total impact is to the funds You can see that the general fund appropriation is increasing by $5,822,594 in each year of the biennium. And the other special revenue funds allocation is decreasing by that same amount for a net zero across all funds. So this just shows you what you see in the budget document. It has all the lines. I'll show you another summary. There's a lot of numbers here. Don't worry. You don't need to fully understand this. I just want to show you this is what I go through to make sure that the change that's happening in the budget matches the Revenue Forecasting Committee. That's all I'm doing here is comparing it to the final Revenue Forecasting Committee report, which is this first column. This is the fiscal year 2020 in the December 2020 RFC Revenue Forecasting Committee. This is the general fund piece. I go through and compare the December 2020 RFC to what's in the accounting system at the moment and outline what the difference should be. And then I make sure that these changes are the same changes that happen in the budget. And that is what happened in all the general fund accounts. You can see that in total, it's a $5.8 million increase in general fund based on that December 2020 RFC report. Then I do the same thing for all the other special revenue accounts. Again, it's what is the December 2020 RFC? Sorry, it says December 2018. That's not correct. This is December 2020. What is in the accounting system and what is the difference? And again, you can see that the total is a decrease in other special revenues of 5.8 million. I just want to show you that to show you that I went through, I looked at all these lines. What's in the budget matches the December 2020 RFC. Any questions at all about that? Not seeing any. I'm going to stop sharing again. So now that we're done with the initiative document, the green document, we're going to move to the, oh, I do see Senator Claxton. It looks like Deputy Commissioner Mann has a question, so I'll let him.
Go ahead, sir.
Just very quickly to your question around the baseline for durable medical equipment. We pulled that $27.3 million annual spend, all funds, and the reduction, the savings proposal is about $600,000 all funds. That's right around a 2%.
Thank you.
Yep.
Thank you.
So if there's nothing else, we'll move to the purple document. It's our language document. We'll start with line 486. This is part LL, and this part updates the United States Department of Labor Bureau of Labor Statistics Consumer Price Index to be used for cost of living adjustments from the Medical Care Services Index to the Nursing and Adult Day Care Services Index. So this relates back to the initiative we just discussed, and we mentioned that we thought there was some language coming related to that. So this just changes which particular CPI is used for the COLA increase. Seeing no questions, I'll move on to part 00. This part updates the base year for the hospital tax. So this relates back to lines 308, 309 on the green document that we discussed, where it was updating the hospital tax year. This is the language that corresponds with that change. Next, we'll do part SS. This is line 493. This part contains transition provisions for the consolidation of general fund programs from 13 to 4 in the Department of Health and Human Services, Office of Main Care Services. Additionally, all existing contracts, agreements, and compacts currently in effect in the Department of Health and Human Services continue in effect. So this relates to the consolidations that have to do with main care that impacted the general fund. So it's lines 138 through 143 and 319 through 324. What this is doing is it's allowing for the department to, after the budget is done, everything that's going on this session puts funding in the accounts that currently exist. So when we move into the next year of the budget, these accounts that they're, through these consolidations, trying to eliminate and move funding elsewhere would still be there with small amounts of money in it. This language allows them to move the funding that's in those accounts to the account that it now resides in, so that as we move on to the next year, the baselines for these accounts will be nothing and all the funding will be where it's supposed to be. This language has to be here because we can't do our fiscal work on the budget assuming this change is going to happen, because the legislature has to approve this change. So we have to do all the other changes that are in the budget as though things are as they currently exist. What that means is if you look at one of the accounts that is being eliminated, you might actually see another initiative in it that gives it either an allocation or appropriation. That's the way we have to go through it. But this language allows that funding to be moved later by the department so that it's all in the place it's intended to be in the end. So it's very general language, but it's very important language to complete those consolidations.
I don't see any questions.
So we'll move on to line ZZ, which is the last part, which means it's the last thing we're going to look at in our round one of these work sessions. This is line 500. This part authorizes the Department of Health and Human Services to transfer available balances of appropriations between the main care general fund accounts for the 2022-23 biennium. This is general language that's in the budget every year. This is what gives the department the ability to move funding within all the main care accounts they have. So it's been in every budget that I've ever seen.
Any questions? I don't see any.
I don't see any, and that's all I had to walk through with you today.
Thank you. So thank you again for being willing to do this on a Monday and at relatively late notice. Are there any questions that we would like to ask of Luke or Deputy Director Mann in anticipation of going back to the top, starting again, Representative Zager?
Thank you, Senator. I was just wondering, aside from the budget as a whole, is there a place where I could see the like a summary document of what the different places that various funds are sending things to, like a pie charts of all that's been in the last biennium that's come out of the other special revenue fund or federal.
So are you looking for specifically in the main care account where all the funding goes, like what sorts of providers are receiving the funding?
Well, I guess like with each of these line items, we're kind of looking, we're talking about the, piecemeal about, what fund it's coming from or going into. And I'm just looking to get a kind of a global view from the fund side, like how much is of in this fund, how much is going into one thing versus another.
And that's where I would point to when I walk through with you the main care reports that are done. There's a file that comes from the department that's sent out monthly that lays it out by these appropriations. But further than that, I have a report that I do quarterly, which hopefully there'll be a new one through 2 quarters of state fiscal year 2021. It currently only goes through 1 quarter, but it outlines expenditures to specific types of services. That's really the sort of detail we have in the accounting system. It tells you what service it went to, whether it's a hospital, nursing facility, one of the waivers, or to mental health services. There are 22 categories that are outlined on that report. That's on the OFPR website. The link to it, I believe, was also in the presentation I gave, which is up on the HHS committee webpage itself under the orientation section. So that report's, I think, what you're looking for, because it at least gives you some detail of what types of services are funded through main care. For more detail than that, it might be something that would come from the department just because they have the actual claims data. That's not what's in the accounting system, but I think what you're looking for really is provided in that report.
I appreciate that. I'm sure that you briefed us on it, probably part of the blur of orientation that appreciate it.
Any other questions? Well said, Representative. Any other questions? I don't see any. So we'll thank Luke for his expertise and explanations. Deputy Director Mann for being here and helping us with this. And I guess Mr. Wiley for support. Very good. So I'll look to my analysts to see if there's any particular work you think we need to do now.
I have you in the hot seat, Senator.
That's what I was hoping you wouldn't remember. So last session, I introduced a bill. Why is Anna grinning at me? Gotcha, right? I introduced a bill at the request of the Maine Hospital Association to look into whether there might be a need for what's called a long-term acute care hospital. There's a certain percentage of people who end up in a hospital for long periods of time who never quite get well enough to go to a nursing home, but aren't technically sick enough to be staying in the hospital, keeping a bed out of circulation. It's a relatively small number, but some of these stays, I was aware of one at the hospital where the length of stay was 360 days. This was somebody who they were working on getting off of a respirator, who had heart problems and kidney failure. And at any given time, he was in a lot of ways stable. He just wasn't healthy. And so no nursing home would take him. So he just sat there and sat there and sat there. You know, he got better eventually. But he's the most specific example of somebody who might benefit from what's called the long-term acute care hospital, where you go in anticipating a long stay with multiple medical issues that will require lots of concentrated support. And what's happening now is that our hospitals in state are basically having to create some sort of circumstance like that because they only get paid for really acute days. They don't get paid for convalescent days. So it can be a significant hit financially to the hospital systems who end up with these patients. So the study was commissioned to look at whether there was a state need to develop one of these hospitals. The answer almost immediately came back no, when it was appreciated that to build one of these hospitals is probably $2 million a bed. So that's a lot of money right off the top. And so they came up with some other recommendations, though, to better understand what the issue is. They looked at the numbers of people who might fall into this category in a 2-year span. They looked at the total inpatient days of people who stayed in a hospital over 25 days, and it was like 70,000 days when patients in the state are in the hospital for a long time. Relatively few went to out-of-state hospitals, and a much smaller number than that, about 0.5%, went to out-of-state long-term care hospitals, because there are organizations that do have these, and I think Massachusetts is the closest one. So we had 100 people who went out of state to other hospitals for long-term stays, and we had less than 60 who went to long-term acute care hospitals. So they were also charged with looking at where a place to put something like this was, but that's pretty much moot. And so their recommendations were to put together 2 comprehensive studies. Excuse me. One would look at a retrospective 2-year study to really get into the weeds about those folks who are staying over 25 days in a hospital and how many of those might meet CMS certified long-term chronic hospital care. The other study was to do the same 2-year retrospective and analyze just the folks who stayed 25 days. The studies overlap a lot, so I'm not sure why it makes sense to do 2 of them. But that was the extent of the recommendations. Excuse me, I didn't get to the mute button fast enough. So that's the report on the task force to study sorry about that, the need for long-term acute care hospitals. So the simple answer is yes, we need long-term acute care hospital beds, but no, it doesn't make sense based on the information we have to think about building them. And it then becomes the decision of the hospital as to whether they want to try to create some long-term acute care beds for which there is a significantly higher reimbursement level, but a lot of upfront dollar cost, and whether they think that's worth it or not. But that was the first step. I'll be talking with folks in the department and the Maine Hospitals Association about whether they want to pursue this or not. They were just looking for some basic starter information, which we can now give them. So that's my report. Are there any questions? And thankfully, Representative Javner wasn't here to assess my contribution compared to hers. So I don't see any questions. All right. What's next on the agenda, Anna?
That's all I have. I had a couple of people who signed up for Wednesday. I didn't know if anybody else might want to take this opportunity to either present today or sign up for Wednesday.
Don't all put your hands up at once.
I'll do the CRC on Wednesday if there's time.
Okay. And Representative Craven?
Yes, I have the HIV/AIDS report ready. I can give that if you like.
Sure. Why don't you go ahead and do that?
I still need to know what I have to report.
I have to go find it.
We'll take a brief pause here.
Representative Perry, I'll send you the email right now that I sent on Friday, okay?
Oh,
or whatever that was.
Thanks.
It's all right. I'll send it right now.
Okay, thank you.
Okay. So HIVAC Maine HIV/AIDS Advisory Committee 2019 Annual Report. Background. Maine's HIV/AIDS Advisory Committee, HIVAC, is commissioned under this commission under Maine statute as part of the statutorily mandated requirement. We're providing the Joint Standing Committee of Health and Human Services with this report. Membership. HIVAC membership consists of a diverse group with varying experiences related to HIV/AIDS in Maine, ensuring representation for the community of which it serves. Currently, the committee includes HIV-positive individuals, medical providers, social service community-based organizations, as well as members of the Maine legislature. Maine Center for Disease Control and Prevention, CDC, Department of Corrections, and the Office of Maine Care Services, as well as the Department of Education, are members of the committee. The function of the committee, in accordance with the Maine statute, continue to be focused on advising the legislature, state agencies, and the Office of the Governor. In addition, an annual report on the status of HIV in the state of the Office of the Governor and the Joint Standing Committee on Health and Human Services is due on March 1st of each year. The 2019 report of the Joint Committee on Health and Human Services seeks to provide more personal and direct experiences among persons impacted by HIV/AIDS. I'm sorry that I didn't actually number those pages. So with a diverse membership and audience, HIVAC is prioritizing unified and comprehensive messaging to increase HIV awareness, fight stigma, and promote quality care. Collaboration between providers, advocates, businesses, and lawmakers, and the community is critical to furthering Maine's role in turning the tide of HIV/AIDS. Among these strategic areas of focus is undetectable, equal, untransmittable, or UU. This important label is widely accepted by national HIV advocate organizations, Centers for Disease Control and Prevention, the National Institute of Health, and public health agencies. It also serves as a clear and succinct tool in educating the public on viral load suppression and treatment as prevention. HIVAC is also working collaboratively with legislatures to address gaps in care, especially in the areas of medication, access, risk reduction, and main care policy. The recent passage of comprehensive prescription drug reform may significantly impact the future of HIV medication access and place Maine on the forefront of addressing the urgency of medication affordability. Some of the resources that is available to people living with HIV/AIDS are some that include the Ryan White Act, housing opportunities for persons with HIV/AIDS through the U.S. Department of Housing and Urban Development, and the Affordable Care Act, developed in 2010 and updated in 2015. The National HIV/AIDS Strategy provides a roadmap in the fight against HIV and focuses on strategic goals aimed at reducing new infections, increasing access to care, and improving health outcomes among people living with HIV/AIDS, addressing HIV-related health disparities, and achieving a more coordinated national response to the HIV epidemic. I don't know if there are people who aren't familiar with the Ryan White Act, but it is a federal program that provides private insurance for people who are living with HIV/AIDS, but it is very expansive and provides lots of different services through the program. While these programs and resources have enhanced the health and well-being of people living with HIV/AIDS, more work is needed to address significant gaps in care. The uncertain future of the Affordable Care Act, inequality and discrimination towards the LGBTQ community, and harmful immigration policy all pose a threat to continued progress towards the end of the HIV epidemic. Main resources and the state's role in the national strategy. An estimated 1,800 people are living with HIV in Maine. People in Maine living with HIV/AIDS may access insurance coverage through Maine's Medicaid program. The state's 1115 special benefits waiver increases the access to 250% of the federal poverty level. And the administration of the Ryan White HIV/AIDS program provides private insurance and medication coverage for people ineligible for main care due to their immigration status or their income up to 500% of the federal poverty level. The historical progress and current efforts are not possible without dedication and collaborative commitment between people living with HIV/AIDS and medical and social services that are provided, state and local agencies, advocates, and a compassionate community. We must remain steadfast and committed to addressing ongoing challenges, ensuring people living with HIV/AIDS can maintain health stability, well-being, and prevent future infections. This can only be achieved when we have quality care systems in place and have opportunities to foster supportive connections with people living with HIV in our community. And the report had all kinds of nifty graphs, and on the back that is on the CDC website, indicating who the populations are in Maine who actually has HIV/AIDS, and other important information if you would like to go there and see it. And I'd be happy to answer any questions.
Any questions for Representative Craven?
Sorry?
I don't see any. Anything else we wanted to do before we entertain the idea of adjourning? I hear one. I see another one. Yes, Representative Meyer.
Yes, thank you, Mr. Chair. I just wanted to remind the committee that Dr. Shaw will be with us on Thursday morning. And we've got an opportunity to ask him some questions. So please submit your questions to Anna and Erin. Even if you've submitted questions, but you've got additional questions based on the changes that were announced on Friday, please remember to do so.
Yes, Representative Lemlin.
Yes, thank you. Senator Claxton, Representative Jabner wanted me to pass it on to you that you get an A for your report.
Thank you, sir, for that. I'll sleep better tonight after not sleeping last night worrying about it. Thank you.
Oh, you're very welcome.
I owe her some flowers or something. All right. Anything else on the agenda? So we're meeting tomorrow. I have 9 o'clock. And we'll spend some more time going line by line through the work that we did the high level of. And we'll be working on getting things in or out of the budget. And then in the afternoon, we'll be doing a public hearing on 4 bills. So in the absence of anything else on our agenda and having benefit of Luke's expertise, sounds like we're done for the day. I'll entertain a motion to adjourn.
So moved.
Thank you. Oh, you don't want to introduce yourself, Senator Baldacci? Is there a second to that motion?
I second it.
Okay, there's a motion and a second.